Good morning, everyone. So today I'm going to talk about one of the very important topic in neurology, that is Guillain-Barre syndrome. In the last class, we dealt with central nervous system infection like meningitis, encephalitis, and brain abscess. Those are also very important topic, but we have done those. So today, let's talk about Guillain-Barre syndrome. Guillain-Barre syndrome is also known as acute inflammatory demyelinating polyneuropathy. So let's analyze the meaning of this term. There is inflammation going on in the peripheral nervous system, which leads to demyelination. Now, myelin sheath is very necessary for the conducting velocity in those neurons. If myelin sheath is damaged, then the velocity of the conduction is severely decreased. So this is the main problem in case of Guillain-Barre syndrome. So this is one of the important cause of peripheral neuropathy. And what type of inflammation occurs here? This is an autoimmune type of inflammation. So with this background information, let's enter into the topic. Now, let's start with a case. Okay, all of you, please focus on your screen here. This case is about a 33-year-old registered nurse who awoke in the morning with a pins and needles sensation and accompanying numbness in her hand. So see, she had pins and needles sensation in the periphery and accompanying numbness in her hand. Now what type of symptoms are they? What type of symptoms are they? Yes?
Peripheral neuropathy, sir. Peripheral neuropathy.
Exactly. Exactly. They are, you can say, they are sensory symptom or they are symptoms of the peripheral nerve involvement or peripheral neuropathy. Okay, good. Let's move on. Upon arising, she became aware of mild incoordination and weakness of her lower extremity. Now, she also had weakness of the lower extremity along with some incoordination, probably because of muscle weakness. The weakness progressed to involve her upper extremities as well, and she was hospitalized by her family physician 3 days later. Now, within 3 days, the weakness has ascended up, and now it has involved the upper extremities as well. But it started from the lower extremity, means lower limb. Now, upper limbs are also involved. She previously had been in excellent health, with the exception of a 4-day hospitalization. Okay, with the exception of 4-day hospitalization 2 weeks earlier for a flu-like syndrome, which consists of mild fever, cervical adenopathy, malaise, and diffuse arthralgia and myalgia. Now let's analyze this. This is important for the etiology. So see that she had been a healthy person before, but around 2 weeks earlier, she was admitted for 4 days in the hospital with flu, probably some viral illness, probably influenza, who knows. So many of the viral illness have similar type of symptoms, which are called prodromal syndrome, like mild fever, lymphadenopathy, malaise, arthralgia, and myalgia. A precise diagnosis had not been established during that time. Probably they just thought it's a type of viral infection and it must have got better by itself. She was taking no medication and used alcohol socially. So she was a social drinker, not a chronic and heavy drinker. Now, what information we get from this much history? So let me summarize this. This is the way you need to solve the case. Always choose some important points. That is, pins and needle sensation in the beginning, that is sensory symptom, and later on motor symptom also came into the picture. The motor symptoms or weakness started from the lower limb and now it has gone up towards the upper limb. Around 2 weeks ago, she was suffering from viral illness. This much information we have. Now let's examine that lady. During the physical examination, there was diffuse weakness of all four extremity, distal greater than the proximal and involving the upper more than the lower limbs. Very clear cut, physical examination findings are there. All four limbs are affected, but see this, the upper limbs are more affected than the lower limbs now, and distal muscles are more affected than the proximal. This is very true in case of neuropathy. Neuropathy involves distal muscle more than the proximal one, whereas myopathy involves proximal muscles more than the distal one. Never forget this golden statement from the clinical medicine. When the patient complains distal muscles more weaker than the proximal, we think mainly neuropathy. But if they complain proximal muscles more weaker than distal, we think of myopathy. Now, in the upper limb, which are proximal and which are distal muscles in the upper limb? Yes?
Proximal muscle, bicep, tricep,
Biceps,
biceps,
triceps are the
proximal, distal forearm
And
muscles.
forearm muscle are distals and bicep and tricep are the proximal.
exactly. Every student know this. Okay, every student can answer this. The muscles which are present in the arm are proximal, and the muscle which are present in the forearm are the distal, isn't it? So muscles present in the arm, biceps, triceps, okay, coracobrachialis and brachialis, all these muscles are there. And in the forearm, you all have different type of flexor and extensor group of the muscles. So that's a pretty easy answer. Just like in the lower limb also, the thigh, okay, and hamstrings compartment, the quadriceps and the hamstring are the upper, are the proximal muscles, and the leg muscles are the distal one. Now, during the grading, they found it's a grade 3 distally and grade 4 proximally. That means rather than this one, this distally and proximally, uh, it's a bit of, mistaken here. The upper limb power is grade 3 and the lower limb power is grade 4, because they have clearly told already the upper limbs are more affected than the lower limbs. So grade 3. Okay, grade 4 is towards the normal, grade 5 is absolutely normal, grade 4 is a slight weakness, and grade 3 is more weaker than grade 4, and grade 0 means absolutely no power. We have done that before. There was mild facial weakness as well, so facial nerve is also affected there. Muscle tone was decreased and vibratory sensation was diminished in the distal lower extremity. The important point is tone is also decreased. The muscle stretch reflexes were absent. So there were no deep tendon jerk present. They were absent. No pathological reflexes were present. So which pathological reflexes, the examiner wants to say here? Which one?
Babinski sign.
Babinski
sign.
Exactly. Exactly. It's a Babinski sign. So there was no Babinski sign. And if Babinski sign is not present there, that means it is not a case of upper motor neuron. Probably it's a case of lower motor neuron. The finding which suggest lower motor neuron are so many, which are given here. So let's list them first. Okay. So what are the findings of lower motor neuron lesion in this case? Now see this. One is muscle weakness. Muscle weakness, which is clear cut. Okay, which is a clear cut feature here. Another one is a tone. The tone is hypotonia. The tone is hypotonia, which is clearly given here. See this? The muscle tone was decreased. The third, stretch reflexes were absent. That what happens in case of lower motor neuron lesion. So there is a reflexia, isn't it? A reflexia or hyporeflexia. And Babinski is negative. And Babinski is actually negative in lower motor neuron also. But if it is present, it is a very, very important finding which suggests upper motor neuron. Never forget this. Babinski is negative or absent in normal case as well as in lower motor neuron. But if it is present, It clearly tells us upper motor neuron lesion is present in the patient. Now this is a clear-cut case of lower motor neuron lesion. Okay, now let's correlate with our history and physical examination. The history clearly tells us around 2 weeks ago she suffered from viral infection, and after that she had a gradual ascending type of paralysis. So if you combine this history and physical examination, Guillain Barre syndrome is a clear-cut diagnosis right from the history and physical examination itself, which we have to confirm by some of the investigation. Let's move on. Now, look at the lab evaluation they have done. Routine studies of the blood and urine gave normal results. Acute viral titer demonstrated a herpes virus titer of 1 to 64. So the lady around 2 weeks ago, she was having herpes virus infection. This titer was proving that. Rheumatoid factor and anti-nuclear antibody were negative. Connective tissue disorder is also one of the cause of peripheral neuropathy or lower motor neuron lesion. That's why this test was done, but they were negative. Urine porphobilinogen, delta amino levulinic acid, and heavy metal screening were unremarkable. Now these are some other causes of peripheral neuropathy. Now porphobilinogen, okay, in case of different types of porphyria. Okay, porphyria is a heme metabolism disorder. These different types of porphobilinogen or abnormal metabolites of the heme metabolism were present in the urine. So it is not that case. Delta amino levulinic acid, similar type of situation. Okay, acute intermittent porphyria, you have delta amino levulinic acid present in the urine, and heavy metal screening, especially done for lead poisoning, because lead is the heavy metal which is important in the causation of peripheral neuropathy. Heterophile agglutination was negative. Now, can you tell me this test is done for which infection? Heterophile agglutination.
Epstein-Barr infection. Epstein-Barr.
Excellent. Okay, all students are answering in the same way. Very good answer. This is done to rule out Epstein-Barr virus infection. Heterophile agglutination test. Very nice. Now, one of the very important investigation was also done, that is lumbar puncture and CSF analysis. So what have they found here? So please pay attention. The CSF was clear, colorless, with a total protein of 75 milligram per deciliter, and CSF glucose was normal, and there was no pleocytosis, means no cell, okay, present in the CSF. What they mean is the cells are not increased than the normal number. So up to 5 is normal. We all know that. That means there is no excessive increase in the cell. CSF cultures were sterile. Now let's analyze what happens to this protein here. What is the normal level of CSF protein?
15 to 45 milligram.
15 to 45.
It's elevated, sir, a little bit.
It's elevated, sir. Looks like.
Exactly, it looks like it is elevated because the normal level is 15 to 45. Very nice. So it is elevated, but there are no cells. So this type of condition is known as albuminocytological dissociation. Albumino, okay, cytologic dissociation. Now, just analyze this term here. This is very important, a term in case of Guillain Barre syndrome. Albumin is increased, and which is clearly seen here. The majority of this protein is albumin. Okay, that's why the term albumin is used. And there are no increase in the cells, so that's not matching. Usually, what happens in case of CSF infection, the protein is also high and the cells are also high. But here, it is not like that. That's why this is known as albuminocytologic dissociation, and this is one of the important features of Guillain Barre syndrome. In this case, the CSF analysis should be done in the second week of illness. then this typical feature would be seen. So every thing is pointing towards, okay, Guillain Barre syndrome. Now with this, let's enter into the topic proper, and I'm sure this type of discussion is very useful for you because you are going to be graduated very soon. When you move on to the hospital practice or private practice, wherever, this is the way you reach to the diagnosis. Some important points from the history, some points from the physical exam, and some relevant investigation. Then you have to analyze it, why these things are there, what the diagnosis can be, what are the differential diagnosis. This is the way. Now, what is Guillain Barre syndrome? Let's talk about it. It is one of the common cause of acute flaccid paralysis, and some other causes of acute flaccid paralysis are, okay, poliomyelitis. See that? Poliomyelitis, transverse myelitis, traumatic neuritis, and botulism. They are more common than the other. Now, let me analyze what is acute flaccid paralysis. Now, flaccid, what's the meaning of flaccid? Yes? What is flaccid?
Hypotonia.
Decrease
No,
power
no,
and
sir.
Decrease
power
tone.
and
Tone is decreased.
Exactly.
decrease
Absolutely,
power results.
absolutely correct. Okay. The meaning of flaccidity is severe decrease in the tone. So this is severely hypotonic condition. Okay. And paralysis means loss of power. So flaccid is hypotonic, paralysis is loss of power. So these are the typical conditions which leads to that. Guillain Barre syndrome, poliomyelitis, transverse myelitis, traumatic neuritis, and botulism. Now, poliomyelitis is caused by poliovirus. It's an enterovirus group, okay, belongs to enterovirus family, and then it specifically, okay, affects anterior horn cell in the spinal cord, and sometimes even the cranial nerve nuclei in the brainstem. We have a condition known as bulbar polio also. This is a very complicated situation, but usually poliovirus affects the anterior horn cell of the spinal cord. Now, that anterior horn cells are important for origin of motor neuron. We all know that motor neuron originates from there. So what will happen if those cells are damaged by poliovirus? Yes, what will happen to the patient now?
So no contraction of the muscle.
Paralysis.
No
Tone is
movement.
really decreased.
Lower motor
And
No
neuron.
motor
movement of
symptoms.
the muscle.
Exactly. Okay, very good. All of the students are answering correctly. That means you can answer in a different way. The muscles which are supplied by those nerves are paralyzed. So that is lower motor neuron type of paralysis. And this paralysis or muscle weakness in polio is asymmetrical. It doesn't involve the same group of muscles on both sides of the body. So it is asymmetrical, and there is no involvement of the sensory system. These are very important points regarding polio. Never forget it. Polio is almost eradicated from this world. Only few countries are still having some of the cases, and this is done by the vaccination. And there are two types of vaccine which are available regarding polio. So which vaccines are those? Which vaccine?
Sir, one is
Polio
live and one is
how can
killed.
be
Oral polio.
One is killed and one is live.
injecting? What is
Oral
injecting?
and IV.
Good. Okay, good answer. So every student know that one is called oral polio vaccine, another is called injectable polio vaccine, OPV and IPV. Okay, also known as Sabin vaccine and Salk vaccine. Okay, Sabin means live, oral. Okay, remember our great teacher Sabin sir. Then Salk vaccine is the killed one, isn't it? So this is the way. So remember, whenever you talk about some particular term, this is the way you need to have some information quickly. Okay, so I want all the student, whenever you make your note, whenever you take the printout from our presentation, all the extra things which I am explaining now, you can write on the side, so that later on it will be very, very useful for you. And if you want some more information, you can go to those particular topics either from the internet site or from the textbook or whatever you want. Okay, get that extra information. Don't keep it. Oh, I'll study it later on in that particular time. That time will never come. So this is the way you need to deal. Let's move on now. Another is transverse myelitis. Okay, let's pay attention. Transverse myelitis means the spinal cord is affected transversely, okay, like a straight line. The whole circumference of the spinal cord is affected here. And myelitis is inflammation of the spinal cord. Now, this is a very interesting situation where below than that area of the involvement, okay, below than that area of the involvement, everything is gone. That means there is no sensation and there is no power. But at that site of involvement, exactly at that site, okay, the lower motor neuron symptoms are present. Below than that, the upper motor neuron symptoms are present and all the sensations are lost. And above than that, everything is normal. So this is known as transverse myelitis. Now you may be wondering why this happens. Okay, a very easy explanation I can provide here. Remember the corticospinal fiber which are descending down into the spinal cord. If the spinal cord is affected at T10 level, exactly at that T10 level, the T10 spinal nerves comes out. Now whatever is supplied by the T10, in that area we have lower motor neuron type of lesion, but below than T10 it's upper motor neuron lesion because the corticospinal fibers are damaged there. Never forget this. This is a very important point in neurology. Traumatic neuritis is because of trauma, because of injury of the spinal cord. Okay, so it is also a type of lower motor neuron in that area of injury or damage, but lower than that area it is again upper motor neuron lesion. And botulism. Which organism cause botulism? What is the name of that bacteria?
Clostridium botulism.
Clostridium
Clostridium botulism.
botulinum.
Exactly.
Clostridium botulinum.
This is a very easy question. Okay, so it is an anaerobic type of organism known as Clostridium botulinum. Okay, Clostridium botulinum. So this disease is botulism, and this is a toxin related condition. So this is a powerful toxin which is produced by that bacteria, that is called botulinum toxin. And that botulinum toxin, okay, doesn't allow the acetylcholine to be released. And without any acetylcholine in the neuromuscular junction, those muscles cannot contract, which leads to paralysis. This situation is known as botulism. Botulism specifically involves muscles of the head and neck first, then the paralysis descends downward. So it is in one sense exactly opposite to the Guillain Barre syndrome. In GBS, we have ascending type of paralysis. From the lower limb, it gradually ascend upward, but botulism, we have descending type of paralysis. It starts from the head and neck and slowly descends downward. Okay, so these are some of the important information. Let's move on. Now let's introduce this topic a bit further. Some of the important points are highlighted in the beginning so that the interest will be grown, okay, regarding the topic. This is acute inflammatory demyelinating polyneuropathy. This is another term, we already explained this. Is an autoimmune disease that is characterized by progressive areflexic weakness and mild sensory changes. So this is a hallmark of lower motor neuron. There is areflexia, there is weakness, and it also has some type of sensory system involvement. Remember, this is an autoimmune disease. The sensory symptom often come before the motor one. Remember that case, that lady has pins and needle sensation in the beginning, okay, followed by weakness. So that was a typical case. About 20% of the patient end up with respiratory failure. That's why this condition is very serious. Around 20% of the time, the patient will end up with respiratory failure. Now, what is the cause of respiratory failure here? What is the cause?
Sir, because
Paralysis of respiratory muscle.
paralysis of diaphragm and respiratory muscles
Diaphragm.
paralysis.
Exactly.
Phrenic involvement.
Absolutely. This is, remember, this is a muscle paralysis case, and it is ascending type of muscle paralysis. So when the muscle involvement is ascending upwards towards the head and neck area, then those respiratory muscles are also paralyzed. That is the cause of respiratory failure. Now we have only one type of treatment available if there is respiratory paralysis, and that is ventilation, mechanical ventilator. So without mechanical ventilator, in case of respiratory failure, the person will die. There's no other way. Yes, we have so many different medicine. We can use IVIG, we can use corticosteroid, but they take time to act. And if the patient is not breathing, then patient can quickly collapse. Okay, so mechanical ventilation is a very important part of the management in case of respiratory failure cases. The most common presentation in Guillain Barre syndrome is ascending paralysis. Every student know that by now. It is associated with distal paresthesia and loss of deep tendon reflexes. That case which we discussed also having these things. And the progression is often maximal by the end of 4 weeks, and after that it is slowly improve. So you can say the natural history of the disease lasts around 4 weeks or 1 month. After that, either the patient die because of respiratory paralysis, or they improve slowly, and some of the patient will have some neurological sequelae as well. So let's move on. Now, what are the causes of Guillain Barre syndrome? 2/3 of the patient had an antecedent upper respiratory or GI infection or syndrome from 1 to 6 weeks prior to the onset of weakness. So that's the interesting thing about discussing the case in the beginning. Remember that case, okay? Around 2 weeks prior of paralysis or weakness, she was having some sort of viral prodrome, okay, like myalgia, arthralgia, sore throat, runny nose, moist eye, and all those things. So almost 2/3 or almost 65 to 66% of the patient have prior upper respiratory or GI infection. So this history has to be taken. If patient is not providing that information, you keep on asking that question. Can you remember? Do you have this type of problem in the recent past? Then sometimes they will give the answer, because people easily forget. They don't take this type of things easily, isn't it? Because these are the minor type of infection for them. Regarding the viral infection, the infection occurs with influenza virus, Coxsackie virus, Epstein Barr virus, or cytomegalovirus. They can cause upper respiratory tract infection very commonly. See this? Influenza, also known as flu, okay? Flu or influenza virus, Coxsackie virus, it commonly leads to herpangina. Okay, herpangina is a very common infection in the oral cavity or back of the throat. It can also lead to hand, foot, and mouth disease. Don't forget that. Hand, foot, and mouth disease. And some other infections are also quite commonly caused by Coxsackie virus. In the last class of encephalitis, I talked a little bit about that also. It also leads to pleurodynia. It also leads to myocarditis, specifically by Coxsackie B virus. Now, which disease is caused by Epstein Barr virus?
Bracket lymphoma.
And
Oropharyngeal
Nasopharyngeal carcinoma.
okay, and one more, the acute disease, acute infection caused by Epstein Barr virus is called, what is that? What is the name?
Kissing disease.
Cushing's disease. Very good. Cushing's disease, also known as glandular fever, also known as infectious mononucleosis. So these three are the synonym. Cushing's disease, glandular fever, or infectious mononucleosis. And it is a carcinogenic virus or oncogenic virus, you can say. So Burkitt lymphoma and nasopharyngeal carcinoma are very commonly caused by Epstein-Barr virus. So see, this type of questions very commonly asked in the exam. A cytomegalovirus, it doesn't cause severe infection in immunocompetent people, but if they are immunocompromised, then it can cause a bit serious infection. Immunoglobulin M antibody, okay, are identified in many people with Guillain Barre syndrome. That clearly suggests us they had a recent infection with these viruses, okay, isn't it? You all know the meaning of IgM and IgG antibody. IgM means recent infection or ongoing infection. IgG means it is a little bit of chronic infection in the past. So if IgM is there, then it almost confirms, yes, we have this infection just now or a little while earlier. Now, some other causes are bacterial. Now, Campylobacter jejuni and Mycoplasma pneumoniae infections are the commonly associated infection with Guillain Barre syndrome. Never forget this Campylobacter jejuni. So let me underline this. Now, what infection is caused by Campylobacter jejuni? Yes? Which infection?
Gastroenteritis.
Diarrhea, sir. Diarrhea.
Diarrhea.
Gastroenteritis. Gastroenteritis.
Guillain Barre
Very
syndrome.
good. Very good. This leads to acute gastroenteritis, or you can also call it diarrhea. And this type of diarrhea is having blood in the stool. So we also can call it bloody diarrhea. Campylobacter jejuni. Don't forget that. So this is also an important history. We should ask this question in case of Guillain Barre syndrome, probably 1 week or 2 weeks prior to this weakness. Do you have this type of diarrhea which have blood in your stool? Specifically ask that question, okay? Try to find out the information. And Mycoplasma pneumoniae usually causes atypical type of pneumonia. Atypical, dry cough, no fever, very dry hacking type of cough. This is quite common. Vaccination can be responsible for the causation of Guillain Barre syndrome in few of the cases. Now see that this is the evidence for that vaccination. Many cases of acute inflammatory demyelinating polyneuropathy, AIDP, acute inflammatory demyelinating polyneuropathy were reported after vaccination for swine influenza, especially in 1976. So they believe vaccination may be responsible in few of the cases. And then the several cases have been reported after immunization against rabies, influenza, measles, mumps, or even rubella. So even MMR vaccine may be associated with some of the cases. But that doesn't mean we stop immunizing people with these vaccines. That is not the meaning here. Okay, some of the cases have been reported because of the vaccination. Now, probably the proteins or the antigen which are present in the vaccines, okay, they have started the immunological reaction. That is the explanation. Some malignancies and systemic illnesses can also play the role, like Hodgkin's lymphoma, AML, acute myelogenous lymphoma or leukemia, okay, systemic lupus erythematosus, and hypothyroidism. They can also lead to different cases of Guillain Barre syndrome. Let's move on. Now we have a bit of time before we go for the break. So what is the pathophysiology of Guillain Barre syndrome? So many points you already know. This is an autoimmune disease, and it targets the myelin sheath in peripheral nervous system. So remember these three important points: autoimmune disease, myelin sheath, and peripheral nervous system. Then everything else would be very easier. So it is believed to be caused by an immunological attack that is directed against the myelin component. That's why it is also known as demyelinating polyneuropathy. So multiple nerves in the peripheral nervous systems are attacked. So this is an important cause of peripheral neuropathy. Both cellular and humoral immune mechanism appear to play a role. Both T cell and B cell, okay, both are involved in the pathophysiological mechanism. And regarding the inflammatory lesion in the myelin sheath, it consists of a lymphocytic infiltrate, and macrophages are also coming in the picture several days later. So lymphocyte and macrophage both can damage that important area. Now, before I go here, which cell is responsible for the synthesis of myelin sheath in peripheral nervous system? Which cell is that?
Schwann cell.
Schwann cells.
Very good. So Schwann cell, every student know that it's called Schwann cell. Let me write that here. Okay, Schwann cells. So these are important cell which forms myelin sheath in peripheral nervous system. So this type of disease may attack the Schwann cells or the myelin sheath which is already formed by the Schwann cell. Okay, so both type of things may occur there. The peripheral nerve will suffer from few changes after this autoimmune reaction, and that is they suffer from inflammation which causes perivascular edema, accumulation of the inflammatory cells like lymphocytes and macrophages, and there is demyelination. This is called segmental type of demyelination. And when the nerve is damaged, okay, the nerve distal to the area of damage will develop degeneration. This is known as Wallerian degeneration. So there is a specific term, Wallerian. Distal to the area of damage, the nerve degenerate. And remember, in this case, the anti-myelin antibodies are also present because humoral immunity is involved as well. So we're talking about the pathophysiology of Guillain Barre syndrome. So this is an autoimmune attack to the myelin sheath in case of peripheral nervous system. When those myelin sheaths are attacked by inflammatory cells, okay, what will happen now? They will suffer from segmental demyelination. And if a peripheral nerve is damaged in one particular area, then the distal part of that neuron or axon will die away or degenerate, and that is known as Wallerian degeneration. Wallerian degeneration. Now let's talk about that a little bit. Let's see here. Okay, so for example, this is a cell body of the neuron, isn't it? So in the cell body, these are the dendrites. Let me draw one very easy and simplified picture for you. Okay, so these are the dendrites, and from here, okay, one long structure will originate, and this is the axon. So this is the axon here. Let's say here is the nucleus. So this is the cell body of the neuron. These are the dendrites, and here is the axon. Now this axon is covered by, okay, myelin sheath. Now see this. So which type of cells I am drawing here now? Which cells are these?
Schwann
Schwann
cells.
cell.
Schwann cells.
Exactly. These are the Schwann cells with their nucleus. Now let's say at this exact area there is damage, okay, of this nerve, this area. Now all the area which is distal to this area, that's what I'm talking right now, this area, okay, this area will degenerate, and this is known as Wallerian degeneration. This is known as Wallerian degeneration. So let me write it here for you. Valerian degeneration. Now everything is quite clear. Now, sometimes, apart from Valerian degeneration, the anterograde degeneration can also occur. Anterograde degeneration means towards the cell body. Okay, that can also happen in case of peripheral neuropathy. But more common type of degeneration is the Valerian one. And anti-myelin antibodies are also present because before the break we also talked about that both cell-mediated immunity and humoral immunity are activated. So because of cell-mediated immunity, T cells, okay, as well as macrophages will come into the picture. And if we take a biopsy from that particular nerve, we can detect that. And when humoral immunity is activated, then abnormal type of antibodies are also present. Let's move on. Now, with this, let's talk about what are the clinical features of Guillain Barre syndrome. Okay, now see this. The number one and the most important clinical feature is the ascending type of paralysis, or you can say progressive weakness. Progressive weakness means day by day or week by week, the person becomes more weaker and weaker. The muscle paralysis is increasing. That is the meaning. So it is a progressive weakness which usually begins in the feet or the lower limb, and later on it involves all four limbs, and sometimes it also involves the respiratory muscle. At the time of presentation, 60% of the patient have weakness in all four limbs, and uh, it is easy for us to diagnose because this is a very important point. See this, weakness in all four limbs. And when you examine that weakness, the typical features of lower motor neuron paralysis would be present. There is areflexia, okay, there is severe paralysis or weakness, and there is no tone, which is known as flaccidity. Weakness reaches maximum by 4 weeks in over 90% of the case, and the weakness is symmetrical. Very important difference from poliomyelitis. Polio is asymmetrical involvement of the muscle, but in Guillain Barre syndrome, it is symmetrical. What does that mean? Both lower limbs are affected, both upper limbs are affected. This is symmetrical. In the arms, the weakness may be worse proximally than distally in some of the patient. But we talked about the typical feature of neuropathy. Neuropathy means distal muscles are involved more commonly than the proximal. Okay, but in some of the cases of Guillain Barre syndrome, it has been seen that the weakness may be worse proximally than distally, especially in the arms. Now, at presentation, half of the patient have some facial weakness as well. So this is one of the commonest cranial nerve which is affected. Now, why cranial nerves are affected in Guillain Barre syndrome? Why?
Because cranial
Because
nerves are also
neuropathy,
peripheral
sir.
nerves.
Neuropathy, sir.
Exactly.
Peripheral nerve.
Exactly. Cranial nerves, just like spinal nerves, are also example of peripheral nerve. They are also peripheral nerve. And they are also having myelin sheath, which is synthesized by Schwann cell. Okay, so this is the important point here. Oropharyngeal or respiratory weakness is a presenting symptom in almost 40% of the patient, and this is a very severe manifestation because this patient may develop respiratory failure anytime. They may develop aspiration pneumonia anytime, and they usually land in the ICU of the hospital, and many of them will also need mechanical ventilator. Now, let's talk about the cranial nerve involvement in case of Guillain Barre syndrome. Just now I talked about these cranial nerves are also example of peripheral nerve. That's why they are also equally affected. So it is observed in 45 to 75% of the patient with Guillain Barre syndrome. 75% means a huge percentage. Okay, so it is almost majority of the people. Now, among the cranial nerve 3 okay, to 7, and 9 to 12 may be affected. So almost most of the cranial nerves are affected. You can remember like that. And the common complaints when cranial nerves are affected would be, remember that class or that important exercise which I give to you. See this. Every student or every medical student must know what are the functions of cranial nerve. Forget about the name now. Name has to be known in the serial order. And after that, what are the functions? What muscles are supplied by them? How to test them? Everything should be in tip of your tongue. So if a facial nerve is affected, then there will be facial droop. And this facial droop is mimicking Bell palsy. Now, Bell palsy is idiopathic type of facial paralysis. It is a lower motor neuron type of facial paralysis, Bell's palsy. So it almost looks like Bell's palsy. Please do not use the term Bell's palsy for other type of facial paralysis, okay? Bell's palsy is importantly idiopathic condition. Yes, this is very common in the clinical practice. It is a lower motor neuron type of paralysis, but if the facial paralysis is caused by Guillain Barre syndrome, we don't call that Bell's palsy. So it is a differential diagnosis of Bell's palsy. You have to understand like this. Now, what is the characteristic feature of this facial paralysis in Guillain Barre syndrome, just like Bell's palsy? Who can answer this? What happens to the face?
Sir, the face, one angle of the mouth goes drooping, sir, and the other angle will goes upward, sir, in case of Guillain-Barré syndrome, sir.
Good. That's a good point you have told. Very good. Any other student?
Sir, the area which is paralyzed will be dropped down, sir.
Fish.
And the normal area will be contract.
Okay, good.
Sir,
Agree with you.
two sides
Yes.
not the same.
Okay. Now let me explain this. Many of the students are listening, okay? So please pay attention. This is a very important question which is asked in your exam, especially in the Viva exam or the clinical exam. Now this is a lower motor neuron type of paralysis. Every student know now, LMN type, okay? As a result of this, the whole one side of the face is involved. The whole one side, okay, or both sides of the face may be affected. Remember, this is usually a symmetrical type of involvement. So I'm talking about Guillain Barre syndrome now, okay? So if Guillain Barre syndrome affects the face or facial nerve, then the whole one side or both sides of the face will develop lower motor neuron type of lesion. So the meaning is both the upper part of the face or the lower part of the face would be affected. And upper part of the face means contraction of the frontalis muscle. So the person cannot frown the forehead now, cannot frown the forehead anymore because of the involvement of upper part of the face. And the lower part of the face is examined by angle of the mouth, and the angle of the mouth will droop downward in the affected side, and it is pulled upward if that side is not affected. But if there is a bilateral involvement, then we cannot see that type. It cannot be pulled up now because that side is also affected. This is very important point. And the saliva is trickled from the corner of the mouth. There is collection of the food in between the cheek and the gum. Okay, the person cannot chew the food or cannot move the food inside the oral cavity. The person cannot blow the cheek. All these are very, very important function. And please do not forget, when the person sleeps, the eye cannot be closed properly. Why eye cannot be closed properly? Which muscles is paralyzed here?
Cranial nerve 3
Fish.
muscles, sir. Orbicularis oculi.
Orbicularis oculi, orbicularis oris.
Orbicularis oculi.
Now, very good answer. This is orbicularis oculi, because I'm asking question very specifically. So you need to listen to the question first, okay? I asked, if the person cannot close the eye, which muscles is affected? This is orbicularis oculi, which is supplied by facial nerve. So that all those things happen in this case. Let's move on. Another important feature is diplopia. Now this diplopia occurs because of involvement of extraocular muscles, and these extraocular muscles are supplied by 3 cranial nerve. So what are those 3 cranial nerve which supply extraocular muscle? What are the names?
3, 4, 6. 3, 4, 6.
medial rectus.
Okay, third, fourth,
Fourth,
and 6th cranial nerve. Excellent. Third, fourth, and 6th cranial nerve, they supply those extraocular muscles. There are different names. Okay, let's not go into the detail. I am sure students know this. Except LR6 and SO4, all other muscles are supplied by third nerve. Just remember that much. And in the exam, you can take a bit of time and remember those names. You don't need to be very hurried up. You can ask 1 minute from the examiner, remember those names and tell the examiner. Just remember that mnemonic: LR6 and SO4. Lateral rectus by 6th cranial nerve, superior oblique by 4th cranial nerve. All other remaining are supplied by 3rd cranial nerve. So that's the meaning. So diplopia means double vision. Dysarthria. Now, dysarthria means the speech, okay, is not very clear. The person doesn't have any problem in the Broca's area or vernix area. Those areas are normal. But the problem is, okay, probably the involvement of the tongue, the involvement of the palate. So if these parts are paralyzed or not functioning well, then the quality of the voice which comes out would be affected. This is known as dysarthria. Dysphagia is difficulty to swallow. Okay, this is also very important feature of cranial nerve involvement, especially glossopharyngeal and vagus nerve. Ophthalmoplegia. Now the whole eyeball cannot be moved. The eyeball movement is paralyzed. If third, fourth, and sixth all nerves are affected, ophthalmoplegia would result. And then pupillary disturbances. Now pupil is supplied by which nerve? Pupil. Which nerve?
Optic.
Third. Third nerve.
Third cranial nerve.
Third nerve.
Third.
Very good. Okay, so two types of answers are coming. Don't say pupil is supplied by 2nd cranial nerve. Okay, remember 2nd cranial nerve is purely sensory nerve. It takes sensation from the retina inward towards the brain. So whenever this question asks, just take the name of third nerve. Third nerve is the motor nerve for pupillary muscles, especially sphincter pupillae, which constrict the pupil. That is the job of third nerve. Dilator pupillae is supplied by which nerve? Dilator pupillae. Yes? Sympathetic. Sympathetic. Very good.
Sympathetic.
It's sympathetic neuron. It is not the job of cranial nerve anymore. It's sympathetic neuron. See this? So this type of knowledge should be there if the question comes. Very nice. Let's move on. Now, some other clinical features are sensory symptom. Though predominantly the motor symptoms are present in the patient, but nevertheless sensory symptoms are also there, especially they come just prior to the motor symptoms start. So mild to moderate paresthesia. Okay, paresthesia means tingling and numbness sensation. This is known as paresthesia. So it may be there in the distal limbs. They are quite common and they often precede the onset of weakness by 1 or more days. So they come prior to the motor symptom. Other groups of symptoms are autonomic dysfunction, because autonomic nervous system is also affected in case of Guillain Barre syndrome. So about 2/3 of the patient have 1 or more of the autonomic abnormalities like follows. First is sustained sinus tachycardia, and it is the most common dysfunction. Now, sinus tachycardia, and this is a sustained one. That means even at the resting period, the heart rate is always high. This is abnormal because there is no stimulation to the heart. and why there is tachycardia. Okay, so probably there is an imbalance between the sympathetic innervation and parasympathetic innervation to the heart. Postural hypotension is the decrease in blood pressure when the person is standing. So this makes the person dizzy. Okay, this is a very important feature, again because of dysfunction of sympathetic neuron. Sweating dysfunction is also because of the sympathetic involvement, because sweating is a function of sympathetic neuron once again, and urinary retention and constipation are more likely to occur. These are again, okay, the function of the autonomic nervous system. If they're affected, then these abnormalities would result in the patient. Now, if I want to summarize what are the clinical feature, I will make them into 3 headings. 1, the motor abnormalities, sensory abnormalities, and autonomic abnormality. Then you will never forget. Few of the points you can always write after that. Now, let's combine everything together and diagnose the case. So diagnosis, if this type of question comes in the exam, I often tell this to my student. You have to include everything from the symptom, from the sign, and from the investigation. So the presence of progressive weakness and areflexia, relative symmetry, mild sensory involvement, cranial nerve involvement, autonomic dysfunction, and absence of fever, we can clearly think about Guillain Barre syndrome. So see this progressive and ascending type of weakness, loss of reflexes, symmetrical involvement, mild sensory involvement prior to the weakness of muscle, cranial nerve involvement, so we have to examine all the cranial nerve, autonomic dysfunction, especially sustained sinus tachycardia, and absence of the fever. So these all are, diagnostic point regarding Guillain Barre syndrome. You can do one very important investigation in the lab, that is lumbar puncture and CSF evaluation, and that can show increase in protein beyond the first week, but cell count are less than 10. If they are more than 5, they are usually less than 10 or less than 15. Means in comparison to the rise in protein, the cell count is not high. This is known as albuminocytological dissociation. This clearly they are not matching with each other. Now why I am explaining like this? Please remember the case of meningitis, remember the case of meningoencephalitis, a ruptured case of brain abscess, or any CSF infection. What is happening there? The protein is also high, the cell is also high, that is called pleocytosis. But in this case, only protein become high. The cells are either within normal range or slightly high. So this is known as albuminocytological dissociation. There are some differential diagnosis of this albuminocytological dissociation. Okay, in some of the neurology book, it is clearly mentioned. Now, one of the important condition I want my student to remember is called Froin syndrome. You see this? Okay, Froin syndrome. Now, this Froin syndrome means it's an obstruction of CSF flow. Obstruction of CSF flow, okay, in the region of spinal cord. Now, what happens in this case? The CSF is stagnant there, and because of this stagnation of the CSF, the protein level can be higher than the normal, but cells are not high. So Froin syndrome is one of the differential diagnosis of albuminocytological dissociation. Okay, don't forget that. In some of the textbook, it is also mentioned multiple sclerosis is one other differential diagnosis. Now, regarding the electrophysiological evidence of Guillain Barre syndrome, we need to go for nerve conduction study or nerve conduction velocity test. And if we do that, there would be these typical findings. So have a look here, and these findings are, see this, conduction slowing, block of the conduction, and there is prolonged distal latency. These all are because of peripheral neuropathy. These all are because of damage to the myelin sheath or because of Wallerian degeneration. So this is also one of the important tests we can do just to confirm the condition of peripheral neuropathy. Let's move on now. Now let's talk about a very important clinical part of this class, that is differential diagnosis. Remember, many other conditions can also result in weakness or paralysis or lower motor neuron type of paralysis. So that's why the list of differential diagnosis is long. Poliomyelitis, already talked about. See this? Poliomyelitis. So what are the important points which separate poliomyelitis from Guillain Barre syndrome? So let me.
Asymmetrical paralysis.
Asymmetrical muscle involvement.
Asymmetrical paralysis.
Very good. Never forget the single most important point. Poliomyelitis is asymmetrical involvement. Guillain Barre syndrome is symmetrical involvement. Guillain Barre syndrome has some type of sensory involvement. Polio never has sensory involvement. Poliomyelitis is a purely motor form of involvement. And poliomyelitis usually, attack children, especially in those areas where vaccination is a problem. If vaccination is done all over, means 100% of the vaccination, remember, poliomyelitis would have been eradicated long time ago. So these are some of the important points. Transverse myelitis, okay, we'll talk about that a little while later. I've included one slide regarding transverse myelitis. Okay. Now, periodic paralysis, very interesting condition. This is a hereditary condition, okay, which may run in the family. In this condition, there is problem in the ionic channels in different tissues or organs of our body. Now what happens after the person takes heavy carbohydrate meal, the person, okay, feels weakness after certain time, maybe after about half an hour to 1 hour, the person feels weakness. And if the person is sitting on the chair, the person cannot stand. If the person is taking a nap, usually that's what people do, isn't it? After taking a good carbohydrate meal in the lunch, they go to bed for a certain period of nap. They cannot even wake up from the bed. Okay, they think they cannot move their limbs. This interesting type of situation is known as hypokalemic periodic paralysis. And during that time, if you take blood and send that blood for the potassium analysis, hypokalemia is seen. But in other time, hypokalemia doesn't occur. So this is a very interesting type of situation. So it can be considered as a differential diagnosis because of paralysis. Hypokalemia is another condition. Now this is a hypokalemia means the potassium level is consistently less than 3.5 milliequivalent per liter as a result of either chronic type of gastroenteritis or diarrhea and vomiting, isn't it? So we all know in hypokalemia there is muscle weakness. Diabetic neuropathy, damage to the nerve because of chronic effect of diabetes. This is one of the long-term complication of diabetes mellitus, neuropathy. So all type of nerves are damaged here. Toxic neuropathy like organophosphate poisoning and lead poisoning, both of them can damage the peripheral nerve. Myasthenia gravis, I'll take a class about myasthenia gravis later on in neurology. This is also a type of autoimmune disorder where anti-acetylcholine receptor antibody are produced. Now, what is the What is the result when anti-acetylcholine receptor antibodies are present? What happens to the patient?
It will block the
They will
receptors.
block the neuromuscular
To
junction. The
block the
person
neuromuscular
feel
junction.
weakness in the evening time, sir.
Contraction, sir.
The person will feel weakness in the evening time.
Exactly, exactly. Okay, so let me write that for you. Sorry. See here, anti-acetylcholine antibody. These are the hallmark of myasthenia gravis. They will block the nicotinic receptors in the neuromuscular junction so that acetylcholine cannot act on them and there will be no muscle contraction. This disease has some typical clinical features. In the morning time, okay, in the morning time, the person is no more weak. The person can do all the necessary job. Even in the daytime, the person can do that. But towards the evening time, all those neurotransmitter probably accumulated in the neuromuscular junction will be depleted, and the person starts to feel very weak. And the weakness starts from the facial area and slowly goes downward. I'll take a class regarding myasthenia later on. Now, botulism is another condition which you already know a little bit. I have also included one slide regarding botulism, so we'll talk there. Malingering and conversion disorder or conversion reaction, these are psychiatric condition. Okay, these are psychiatric condition, especially the conversion reaction, where the person has certain neurological problem. Very common in ladies, okay, or the young ladies, and they often complain to their family or to the husband or to other people that they are having weakness of the limb, they cannot even move them. This is not a deliberate one. Remember, they are not doing this knowingly. Okay, so we should not blame them. You are doing this knowingly. This is not the case. This is a conversion reaction. And one of the very important point here is they may be having certain stress in their life, and this is known as reaction to those certain stress. To differentiate conversion reaction from real organic illness which is causing neuropathy, we need to just do the jerk analysis or jerk test, a deep tendon reflex test. Just take a knee hammer and try to elicit the reflexes there. In conversion reaction, the reflexes are normally present, but in case of Guillain Barre syndrome, they are absent. We already know that. Malingering, is showing that symptom knowingly. Malingering is a different situation from conversion disorder. Spinal injury is a traumatic neuritis. This is because of a road traffic accident, because of fall from a height, because of vertebral fracture. So many causes of spinal injuries are there, and the person can also have weakness in this condition. So these are the differential diagnosis. Now let's talk a little bit about transverse myelitis. Now, please focus there on the slide. Transverse myelitis means, see there, it's inflammation of both sides of one section of the spinal cord. In other words, the whole circumference of the spinal cord is affected, and this is a transverse type of inflammation. In this condition, the myelin sheath is damaged, definitely, but which cells form myelin sheath in spinal cord? Is it the same Schwann cell or something different?
Oligodendrocytes.
Oligodendrocyte.
Oligodendrocytes.
Very good. Okay, it is oligodendrocyte. Excellent. This can cause pain, muscle weakness, paralysis, sensory problem, and bowel and bladder dysfunction. These are the functions of our spinal cord. So pain, muscle weakness, paralysis, sensory problem, and bowel and bladder dysfunction. And remember, I already discussed this in the beginning of the class. There are different type of manifestation at the site of inflammation from where a particular lower motor neuron originate. In that area, the lower motor neuron type of manifestation will be there, but below than area of affection, it is upper motor neuron type of lesion, and above that everything else is normal. Several factors can cause transverse myelitis, like infection and immune system disorder, like autoimmune diseases. One of the important autoimmune diseases is multiple sclerosis, which can affect spinal cord as the form of transverse myelitis. Most people with transverse myelitis recover at least partially, and those with severe attacks sometimes are left with major disability, and this is known as neurological sequelae. Sometimes they are left with uh, persistent type of paralysis. Sometimes they are left with spastic paralysis of the lower limbs. Okay, so those type of things. Let's move on. Now let's talk a little bit about botulism, though many students can write something already. Clostridium botulinum is the bacteria which cause botulism condition. This Clostridium botulinum is a type of anaerobe. Remember this, it's an anaerobe. All Clostridia are anaerobe. They produce a toxin. This is a very powerful toxin. This is known as botulinum toxin. And this toxin, see this, blocks the release of acetylcholine from, okay, from where? From where acetylcholine is released in neuromuscular junction? Where?
Synaptic vesicles. Synaptic vesicles.
Synaptic.
Exactly. These are called as presynaptic vesicle. It is clearly written here. Remember, synapse. Neuromuscular junction is there in the middle. Okay, proximal to that is a presynaptic neuron. Distal to that is a postsynaptic neuron. So in that presynaptic neuron, there are vesicles, and inside the vesicle, the neurotransmitter is located. So acetylcholine is a neurotransmitter. So when the proper signal comes or action potential comes in the neuron, the acetylcholine will release outside, but that release is blocked by botulinum toxin. So always remember like this. So symptoms include double vision or diplopia, blurring of the vision. These are because of involvement of those extraocular muscles in our eyeball. Patient may also have ptosis. Okay, so what is ptosis?
Drooping of the upper eyelid.
Drooping of the upper eyelid because of damage of cranial nerve 3.
Exactly, drooping of the upper eyelid, drooping of upper eyelid. Okay, this is called ptosis. And levator palpebrae superioris is the muscle which is commonly affected there. This muscle is supplied by oculomotor nerve or third cranial nerve. But in this case, rather than involvement of this nerve, the muscles are directly affected. The muscles are directly affected. Slurring of the speech is another one. Difficulty swallowing or dysphagia, dry mouth, and weakness of the muscle. All these are important features of botulism. Now, if you pay attention there, usually head and neck muscles are affected first, and slowly the paralysis is moving downward. That's why it is also known as descending type of paralysis. Descending paralysis. See this? Okay, so don't forget this. Descending paralysis. Important example is botulism. Sometimes it can affect the respiratory muscle, which may cause respiratory failure and even death. And there is one important condition which may occur in a very small babies, that is known as infantile botulism. That infantile botulism is associated with honey, and in many places in the world, they usually give honey or those type of things to the very small babies. Even after a few days of birth, they used to give that. That is not a good practice at all. Okay, there may be spores of Clostridium botulinum. They may go into the GI tract. Now we're talking about the differential diagnosis of Guillain Barre syndrome. Now, the time has come to talk about what are the lab tests we do in a case of Guillain Barre syndrome. Now, some of the biochemical screening tests are electrolyte level, like which electrolyte is important here? Yes, which one?
Hypokalemia occurs, so potassium.
Potassium level.
Rule out hypokalemia.
Hypokalemia occurs, so we need to watch
Exactly.
potassium.
Exactly. Among all type of electrolyte, potassium is very, very important here, because hypokalemia can lead to muscle weakness. So we need to rule that out. Very good answer. Liver function test routinely done in this type of situation. Okay, liver function test, the same illness, the same etiology which may be causing this type of problem like paralysis can be affecting liver also. Remember, though Guillain Barre syndrome do not directly affect the liver, if connective tissue disorder are the causes of this type of peripheral neuropathy, then liver can be affected. So we need to rule that out. Even renal function test should be done. Creatinine phosphokinase. Now, this is the enzyme which is present inside the muscle. So, if muscles are affected, and as a result of that, the person is having weakness, then CPK level may be high. So, just to rule out myopathy, CPK level can be done. ESR to rule out connective tissue diseases again, where ESR is high, and any other infection and inflammation situation in the body. Blood test to exclude other condition. Okay, we have to do routinely. CBC, what is a hemoglobin level, what is a platelet count, and all those things very routinely. Now the specific type of investigation in this situation is CSF analysis. Many times we have talked about this in today's topic. There is albuminocytological dissociation in case of Guillain Barre syndrome. So the meaning of that is increased CSF protein without an increased WBC count. That's why it is known as albuminocytologic dissociation. About 2/3 of the patient who are having Guillain Barre syndrome, okay, they have this albuminocytological dissociation in the first week itself, but still look at the percentage in the second week. 82% have positivity of albuminocytological dissociation after first week or in the second week. That's why we like to do this lumbar puncture after 7 days of the symptom. So the percentage is very high. That is the important point. There is no association exists between protein level and the clinical severity. So what does that mean? Let me explain this by giving 2 examples to you. One patient, when we do CSF analysis, one patient of Guillain Barre syndrome has a protein of 100 milligram per deciliter, and another patient is having protein of 75 milligram per deciliter. Now, that 100 milligram per deciliter patient will not have severe symptom in comparison to 75 milligram per deciliter protein patient. So that doesn't signify anything. Stool culture can be done and it may confirm Campylobacter jejuni enteritis. Okay, so this may be present. Okay, let's move on. Okay, now see there. So patients with this Clostridium jejuni enteritis, remember there are so many causes or etiology of Guillain Barre syndrome. Okay, so let me quickly revise those once again. Different type of viral infection can lead to Guillain-Barre syndrome. Some of the GI infection, one of the important one is Campylobacter jejuni, that can lead to Guillain-Barre syndrome. Mycoplasma pneumoniae, a type of bacteria, can lead to Guillain-Barre syndrome. Some of the vaccinations can lead to Guillain-Barre syndrome, and some other malignancies as well. Among them, the Campylobacter jejuni enteritis, if it is causing Guillain-Barre syndrome, then it has got aggressive course, okay, and a slightly worse prognosis. So these are some of the important points. That's why history taking is very, very necessary here. Now, what is the role of imaging study, or what are the role of radiological study? Imaging study as such are not necessary for the confirmation of Guillain-Barre syndrome. For this condition only, we don't need any of this type of investigation, but we have a long list of differential diagnoses, remember that. So if you are in doubt to rule out other differential diagnosis, we have to go for imaging study. This is a very good way of answering. So MRI of the spine is sometimes necessary to rule out spinal cord lesion or compression of some nerve root, which may mimic, okay, AIDP, acute inflammatory demyelinating polyneuropathy, or Guillain-Barre syndrome. So MRI can be done if a case is suspicious. Chest X-ray can be done in children if you believe Mycoplasma pneumoniae is causing infection there, and the same mycoplasma is responsible for Guillain-Barre syndrome. If you believe, if you suspect, just go for the chest X-ray. It may show some of the patches of atypical pneumonia there. Apart from imaging study, the nerve conduction study or nerve conduction velocity study is important one here. It can document, okay, some important finding, okay, like see there, demyelination, which is known by slow conduction in nerve conduction study, and there is a latency, the distal latency, we say prolonged distal latency, which is another feature of demyelination. So these are important examination or investigation in case of Guillain-Barre syndrome. Now, what is the role of pulmonary function? Why we go for pulmonary function test? So you can answer it very easily, because there is a chance of respiratory paralysis in a case of Guillain-Barre syndrome. So I want to make sure whether it has already there in the patient or not. So to confirm that, pulmonary function test can be done, and these are done by spirometric analysis. Spirometric analysis, like see here, inspiratory pressure and measurement of vital capacity. So these tells us whether the lungs are functioning well or not, whether the respiratory muscles are involved already or not, and whether the diaphragm is still strong enough or not. So all these are important tests. Now, finally, what is the treatment? What type of treatment can be done in a case of GBS? Now, please pay attention, important class for you. Mechanical ventilation is required in about 1/3 of the patient with Guillain-Barre syndrome, and the duration of that ventilation lasts for an average of 7 weeks. 7 weeks is a long time. Okay, see this, 7 weeks. So that means the amount of time taken for the recovery is quite long in the patient who are having respiratory failure. We need to go for intubation, put an endotracheal tube inside the trachea and connect that endotracheal tube to the mechanical ventilator. If that is not possible or difficulty to do, then you can go for tracheostomy also. Now, there is some advantages of tracheostomy over intubation, and some of the advantages are intubation, okay, is a long type of tube. Endotracheal tube is a longer tube which is kept inside the trachea, and there is a cuffed endotracheal tube. It has to be secured by inflating the cuff. So we cannot keep that inflated cuff for a long time. What happens if we do not, deflate the cuff for a longer time? What happens?
Pressure necrosis.
Excellent. Excellent answer. Okay, pressure necrosis of the walls of trachea. So you cannot do that. You have to keep on changing the tube. And this is quite a cumbersome procedure, isn't it? Putting a tube is not that easy. So many of the doctors inside the intensive care unit may simply opt for tracheostomy. Tracheostomy is a very short tube. The cleaning of the airway is also very easy. And later on, okay, after removal of the tracheostomy tube, everything will be all right. So it's their choice. It depends how long the patient is going to stay. Remember, the bedridden patient need prophylaxis against thromboembolism. So which type of prophylaxis you want to provide here? Which drug?
Heparin and
Heparin
warfarin.
followed by warfarin. Warfarin.
Exactly.
Heparin followed by warfarin.
Heparin followed by warfarin. Excellent. To start with is heparin or low molecular weight heparin followed by warfarin. Corticosteroid is another very important form of the treatment, okay, in the case of Guillain Barre syndrome management. Remember the role of corticosteroid here. There is formation of abnormal antibody known as anti-myelin antibody. There is, okay, the role of cell-mediated immunity as well as humoral immunity, and we need to suppress them. Corticosteroids are the wonderful drug to do that. So corticosteroids are always used. Another important drug is immunomodulation with IVIG or intravenous immunoglobulin. Intravenous immunoglobulin, okay, very important drug, as well as plasmapheresis. This plasmapheresis also can be done. Now, IVIG is also used in some other disorders, not only here. So can you tell me what are those other disorders where IVIG is used as a treatment?
ITP.
Kawasaki disease. Kawasaki disease.
Very good.
Erythroblastoma fetalis.
Okay, excellent.
ITP. ITP.
Says ITP, okay, ITP,
Erythroblastoma.
Kawasaki disease, very good. Kawasaki disease and even erythroblastosis fetalis. I completely agree with you. Okay, case of erythroblastosis fetalis. ITP and Kawasaki disease are the very important example for you, where we can use IVIG for the treatment. Now, this IVIG has got a certain role to play. Remember, those abnormal antibody, they cannot go and fix on those tissue, the target tissue in the presence of IVIG. That's the important point. Now, plasmapheresis is like filtering of the plasma. So whatever abnormal antibodies are there, those would be removed. So it will lead to faster recovery in the patient. And when they recover faster, there will be shorter hospital stay. So economic burden to the patient party is also less. And when the hospital stay is shorter, the decreased chance of hospital acquired infection is also there. Remember, ICU is not a good place to stay longer because there are dreadful bacteria which are present there, like Klebsiella, Pseudomonas, MRSA type of Staph aureus. And if the patient gets those infection, okay, the patient is already having Guillain Barre syndrome. On top of that, the severe infection can decrease the lifespan of the patient. So we need to be very careful. Physiotherapy and speech therapy can be given to the patient later on because there is dysarthria, isn't it? Dysarthria. You have to correct the spelling here. And physiotherapy is definitely because there is a limb weakness, and after the patient recover, prolonged physiotherapy is necessary. So look at this picture here. This is a mechanical ventilator. Okay, this is a tube of the mechanical ventilator, and this is attached to the patient. You can clearly see here. Okay, this is attached to the patient with the help of endotracheal tube. Now, what are the complications of GVS or Guillain Barre syndrome? One is pneumonia. This pneumonia can be aspiration type of pneumonia or other hospital acquired pneumonia. Now, aspiration pneumonia occur because of, what is the mechanism for aspiration pneumonia in this case? Yes, I want to hear some answer here. Why?
Sir, if the
Liquid
gag reflex is
dysphagia.
absent, sir. Sir, if the gag reflex is absent, so it will
Exactly.
also lead to very.
They cannot swallow, sir.
Exactly.
Patient is long time bedridden and the criminal also known also because of this.
Very good answer. Okay, I agree. All the answers here, all are correct. Guillain Barre syndrome can affect all type of cranial nerve. If ninth cranial nerve is affected, if 10th cranial nerve is affected, there is loss of the gag reflex, especially ninth. There is loss of gag reflex. Aspiration is quite common. Another one, patient is having dysphagia. During dysphagia, aspiration is again more common. Okay, and another cause of pneumonia is the patient is bedridden for a long time. If we do not aspirate the fluid or the secretion which is there in the airway, it can itself attract infection. And those hospital acquired infections are also quite common in this type of cases. Okay, so see, there are so many reasons we can give. Sepsis. Okay, sepsis is also quite common. UTI is very common in this type of people. We have to catheterize this patient. Okay, otherwise they will wet the bed, and this catheterization itself is a risk factor for urinary tract infection. Pneumonia is also quite common in them. If the nurses who are there do not take care of the patient properly, then bed sore or decubitus ulcers are also quite common. Now see this? So all of these will easily lead to sepsis. Now this decubitus ulcer or bed sore or bed ulcer, it shows the quality of the service patient is getting in the hospital. If the patient is having bed sore inside the hospital, that shows very poor quality of the service. And this is a very, very difficult condition to handle or treat. Deep vein thrombosis is an important complication because of prolonged immobilization. So we need to be careful. We need to give prophylaxis for that thrombosis, either heparin or warfarin, and then timely massage of the lower limb. Okay, massage or a bit of pressure on the lower limb. Urinary tract infection is another common type of complication. Now, at the end of this topic, let's talk about the prognosis. Now, what type of condition is this? What's the chance of recovery? What's the chance of complication? About 75% of the patient have an excellent recovery from Guillain Barre syndrome and regain their pre-morbid condition. Means they completely recover in 75% of the time. That's a good thing. But what about the remaining percentage? Death can occur in about 2 to 6% of the case, and the cause of death in case of Guillain Barre syndrome are maybe cardiac arrest, maybe ARDS, maybe pulmonary embolism, severe bronchospasm, pneumonia, or sepsis. Or any of these, cause can be there for the death. About 10% of the patient have a relapse 1 to 6 weeks after completing the immunomodulatory therapy. Now, this is a very, difficult case now, isn't it? They have relapse again. Relapse means the similar type of signs and symptoms are coming back after you have completed the therapy. Now, same type of treatment is repeated again. You need to make sure patient is the patient having respiratory difficulty or not. If the patient is having that, admit in the hospital, okay, intubate the patient, and then put under mechanical ventilator again, and repeat the same type of treatment. So with this, okay, I have completed the discussion of Guillain-Barre syndrome, a very, very important class. And when you start working in the neurology center or any hospital, you will see a lot of cases of GBS.